everybody. I hope you're all well and staying safe. So today we're going to be taking a closer look at what happens and potentially what can happen when the Pan-Canadian Oncology Drug Review does not recommend that a cancer medication be publicly funded. So if we move on to the overview slide, we'll do just a very quick overview of the drug approval and reimbursement processes. We'll take a bit of a closer look at the pCODR process and the pCPA process, and then we're going to share some research that was actually done on pCODR recommendations and pCPA outcomes, specifically for 2019 and moving into this year. We'll talk about the methodology, the findings, and the conclusions of that research. And then we'll conclude with a little bit of a discussion around what can be done if pCODR says no, and what should you do even if pCODR says yes, given the current situation with COVID-19. Now, just a note before we get started regarding the research we're going to be reviewing does not include any findings from Quebec. However, CCSN does plan on doing some comparable analysis for Quebec in the future. So this is the overall drug approval and listing process in Canada, or really it's of course, as many of you know, it's a series of processes. It's not a single process. But it's important to recognize the various roles here. And by roles, I mean the role of the federal government, the role of the provinces and the territories, and then this third sort of national component to what's being done here. So at the federal level, as many of you know, the federal government approves medications for sale. They regulate their use. They issue patents. They regulate prices. They monitor research and development levels by the pharmaceutical industry. They administer the Special Access Program. And the federal government, unbeknownst to a lot of people, is one of the single largest purchasers of drugs in this country. The provinces play a different role. The provinces review medications for listing on their public formularies. They set reimbursement criteria, and they negotiate the cost of medications, what it will cost a particular province in purchasing a medication. Remember, and I'll come back to this, the reason for this disparity in what they do is because of Section 92 of the Constitution Act, which says, in essence, the delivery of health care is virtually exclusively provincial jurisdiction. So that's why you have this distinction between what the federal government is responsible for and what the provincial government is responsible for. But having said that, there's this third element that a lot of people forget, and it's much of what we're going to be talking about today, which is what I call these joint federal, provincial, territorial, or national processes in which the federal government and the provinces and territories are involved to a greater or lesser extent. And that includes the Common Drug Review, the Pan-Canadian Oncology Drug Review, and of course, pCPA, the Pan-Canadian Pharmaceutical Alliance. So here's the schematic that you just saw on the previous page, but essentially in words. So again, public drug formularies are impacted by these three different policies, or three different levels of policies I just talked about. A manufacturer submits to Health Canada to have a drug approved. CADTH, the Canadian Agency for Drugs and Technologies in Health, of which pCODR, which we're going to talk about today, is a part of. They review medications as well, Common Drug Review, non-oncology medications, and then pCODR oncology medications, and they make recommendations, not decisions. They make recommendations to the provinces, with the exception of Quebec. As many of you know, Quebec does not participate in CADTH. Quebec has its own health technology assessment process. And then after a recommendation is made, that recommendation goes to the Pan-Canadian Pharmaceutical Alliance, who conduct joint negotiations for brand name drugs in Canada, and then the provinces also review medications and make final decisions about what drugs are going to be listed. And again, we'll talk about that in a little bit more detail, just from a continuation or an overview perspective. So as a result of the process within CADA, specifically for oncology drugs, pCODR issues either a positive or negative funding recommendation. Just to go into a little bit more detail here, recommendations made by pCODR and specifically by the Expert Review Committee, or PERC, are based on three things: clinical evidence, cost effectiveness, and patient perspectives. Many of you are aware that there's a patient input process as well as a clinician input process into pCODR. Information is then used again to make recommendations to the provinces to guide their funding decisions. And pCODR takes into account evidence from a number of sources, including, as I said, patient groups, drug manufacturers, clinician-based tumor groups, as well as the pCODR Provincial Advisory Group. And again, I know many of you are aware of, there is an opportunity for input by clinicians and by patient groups on two separate occasions. There's written input at the beginning of the review process, and then once the initial recommendation is made by the Pan-Canadian Expert Review Committee, then there's a second chance for input in this process. So just continuing to move along, we then have the final phase, which is really made up of two components to the overall reimbursement schematic. You've got the pCPA. The pCPA was established almost 10 years ago, the Pan-Canadian Pharmaceutical Alliance, and their mandate is to conduct joint provincial territorial negotiations for brand name drugs in Canada, as we saw a moment ago. These are the members, what we call the standing members of the Pan-Canadian Pharmaceutical Alliance, or the member jurisdictions. They include all of the provinces, they include all of the territories, and they include three of the six federal drug plans. They don't include all the federal drug plans. And all brand name drugs coming forward for funding through pCODR and through the Common Drug Review for non-oncology drugs are considered for negotiation. And that's the key word. They're considered for negotiation. I'll go through that in a little bit more detail in a moment. You're not entitled to consideration, or you're not entitled to go through this process. pCPA's mandate is to enhance patient access to clinically relevant and cost-effective drug treatment options. That's according to them, that's on their website. And it serves this mandate by conducting collective expert informed negotiation of drugs. Through this combined negotiating power, and that's the key, it's this combined power of all of the provinces and the rest of the public drug plans in Canada. Their objectives are to increase access to effective and to clinically effective and cost-effective treatments, achieve consistent and lower drug costs for participating jurisdictions, reduce duplication of efforts so that you don't have to do this in all of the jurisdictions, and improve consistency. Again, this is another key one here, to improve consistency of decisions among the participating jurisdictions. You can make an argument as to whether or not that consistency has been achieved, but it is part of their objectives, at least going into the process. Now, what I'm going to walk you through has just recently been posted on the new pCPA website. I don't know if all of you are aware that pCPA has a new website, but it's just been up for, I think, less than a month, maybe about 3 weeks. And it gives us some important insights into how this typically opaque body does its work. And so what they've set out here are 4 distinct phases that was not on their previous website, but that gives some clarity to how things are done there. So all of this is from their website. These are their words. but essentially the first phase is initiation. So once a recommendation is published by CADIS, so a pCODR recommendation, or by INS, which is the comparable process in Quebec, pCPA issues an acknowledgement letter to the manufacturer advising them that the drug is now under consideration for negotiation by pCPA. So they acknowledge that you got your recommendation, or that a drug manufacturer got their recommendation, and they will at least consider whether or not you can come in. So that's step one. The next step is called consideration, and it's where they consider whether they will enter into negotiations for a drug while also gathering additional evidence or clarification as required. Once this is completed, they will issue a letter to the manufacturer saying, okay, we've considered it, and yes, we are going to enter into negotiations, and the manufacturer receives what's called an engagement letter. That's choice one. Choice two is, we're going to place this on hold for now. We're not sure whether we want to negotiate with the manufacturer on this drug. We're gonna just put it on hold. Or they could say, we've considered negotiating with the manufacturer around this medication, and we've decided we don't want to. And so we're going to close the file, and we're going to tell the manufacturer that in fact we will not negotiate with them. Now, assuming that you're in the first bucket, the manufacturer has been accepted into the process through an engagement letter, then begins the negotiation. A lead jurisdiction is assigned and aims to finalize negotiations within 90 business days from the engagement letter. That's their target, 90 business days. Now that's more than 3 months. That's getting close to 4 months, just so everybody sort of has an idea of that. And then assuming that the negotiations move along during that period, the process is considered complete once the negotiation has resulted in a mutually agreed upon terms and a fully executed letter of agreement, or letter of intent, more accurately. It's actually called a letter of intent, LOI. Or if mutually agreed upon terms are not reached, then the pCPA has issued a closed letter to the manufacturer indicating that it's closed. So you enter into negotiations, you go through this process, and either it results in a letter of intent or letter of agreement with terms and all the rest of it, meaning that it's been concluded successfully, or it has not been concluded successfully. And pCPA sends the manufacturer a closed letter saying, sorry, but we weren't able to successfully negotiate an agreement. Again, all of that detail that I just provided to you has just been posted on the new website, like I said, in the last three or four weeks. So under the old pCPA website, drugs used to be on one of 4 lists. Now pCPA keeps 5 lists, and they're a little bit different and, quite frankly, more transparent, which is a good thing. They also appear to be updating these lists on a daily basis, or close to a daily basis, as opposed to monthly, like they used to do. So, as of May the 5th, so 2 days ago, this is what the lists look like. So the first one that you see, under consideration for negotiation, that's a new list. That wasn't on the old pCPA website. But if we go back to the previous content that I just talked about, that's where you're in that first gate where they're considering whether or not they're even going to enter into negotiations with a manufacturer around that particular drug. So right now, or as of 2 days ago, because these lists are updated every day, as of 2 days ago, there were 16 drugs under consideration for negotiation, 9 of which were oncology drugs. Again, this is a new list, didn't exist previously. Active negotiations, those are ones that are currently going on. This list did exist previously. These are ones that are going on right now. They're actively negotiating with pCPA, and right now, or as of 2 days ago, there are 20 of them, 5 of which are in oncology. You'll recall from the previous slides that not everybody gets into pCPA, and right from the outset, when you're considered, they may decide after consideration that they're not going to negotiate with a manufacturer. Well, there are 75 drugs on the negotiations that were not pursued list. They didn't even enter into negotiations. They never got past the beginning of the process, and there are 75 drugs sitting on that list. The fourth list there, completed negotiations, actually has two subsections, as you saw from the previous slide. So 369 drugs have been negotiated successfully, or I shouldn't say successfully, have been negotiated completely over the course of close to 10 years, 365 drugs. The vast majority of them have been negotiated with a letter of intent, 316. 53 of them, however, did not successfully conclude with a letter of intent. So again, like I mentioned a moment ago, you go into the process, you're in negotiations, things are moving along, and for whatever reason, a letter of intent cannot be concluded, and therefore you get a manufacturer gets a letter from pCODR saying, I'm sorry, or from pCPA, excuse me, saying, sorry, we did not successfully negotiate an agreement here, and you're going on what used to be called the closed negotiation list, now called the no LOI list. And then finally, the last one there, product currently on hold, brand new list. This did not exist before. There are no drugs currently on that list, but again, it's a list that could be utilized if they decide to put certain things on hold, as you saw from the previous content that I went through. Okay, so here is a schematic of much of what I've just talked about. I'm just going to highlight a couple of things here. I'm not going to take you through it again because we just went through it in some detail. It's important to remember that the outcome of a pCPA negotiation is a signed letter of intent, as we just talked about, not a national product listing agreement. Those are still entered into with individual jurisdictions. So again, a letter of intent from a legal perspective is simply a contract to enter into a contract. It is not a legally binding agreement the way an actual contract is. It simply says that I intend, or the parties that sign it, we intend to enter into a legally binding contract. It does not obligate anybody who signs a letter of intent to enter into a legally binding contract. It's just an intention to do so. That's why it's called a letter of intent. The manufacturers, with their letter of intent in hand, still have to get individual product listing agreements negotiated with each of the jurisdictions to actually get the drug into the hands of patients through public funding. And again, why is it this way? Well, it's because of Section 92 of the Constitution Act. There is no obligation on the part of any one of the 19 public drug plans to provide medications to anybody. There isn't. There is no legal obligation amongst any of those public drug plans to provide drugs. That's why the plans are so different, because the delivery of healthcare is exclusively or virtually exclusively within provincial jurisdiction. And just a note that the Canada Health Act does not apply to medications delivered outside of a hospital, including on an outpatient basis. So while we have this federal legislation called the Canada Health Act, 1984, which talks about equity of services and all the rest of it, and a number of other components, portability, and that kind of thing. That's only for services delivered inside of a hospital or by a primary care physician in the context of the delivery of her services to a patient. Once you leave that setting, the hospital setting or whatever, the Canada Health Act doesn't apply, and therefore there is no continuity across all of the provinces, again, because of Section 92. So think of it this way. This is the illustration I often give people. When you're in a hospital and you require, say, a pain medication, you simply get the medication. It's brought to you and you take it. They don't say to you, well, I think you need a pain medication, but before I give it to you, I need your credit card so I can run it through and you can purchase the drug and then I'll give it to you. Everybody knows that's not how it works in a hospital. The reason it doesn't work that way in a hospital, in large measure, is because of the way our system is set up, but also because of the Canada Health Act. The Canada Health Act is essentially an insurance piece of legislation for public insurance of healthcare services. But when you leave a hospital, none of that exists. None of that continuity or consistency, portability exists in that case. Okay. So in order to figure out what can potentially be done when pCODR says no, we decided that we first needed to understand the recommendation, what the recommendation environment really looks like. And so CCSN engaged East Lake Research Group to do an analysis of all of the pCODR recommendations issued in 2019. And the overall finding was that 88% of the recommendations before July 1st, 2019, the work was divided into the first half of the year. The findings were divided, into the first half of the year and the second half of the year. For the first half of the year, 88% of the recommendations issued by pCODR were positive. In the last half of the year, however, only 50% of the recommendations that were issued were positive. There's obviously much more that came out of this, but based on this one finding, it may be that we don't appear to be heading in the right direction with respect to wanting more drugs, not less, ultimately publicly funded in Canada. We don't know if this is a trend because, of course, it's just a snapshot in time, but there certainly is a distinction between 88 positive recommendations and therefore you assume will ultimately make their way through the public funding process, as opposed to only 50%, but we'll delve into this a little bit more. So the methods that were used, all pCODR final recommendations, these were only final recommendations, as we talked about a moment ago. There are initial recommendations, but we're focused on only the final recommendations. All final recommendations issued in 2019 were reviewed, and the following information abstracted. I'm not going to read all of that to you, but we're going to go through some of this or much of this content, including the conditions. That's the third bullet, the kind of cancer, whether solid tumor or not, how the drug is used. We'll talk a bit about that. The phase of clinical trials. We'll talk a little bit about that, and then the provincial funding status. As well. Again, remember, not in Quebec because this analysis did not consider Quebec, and then the pCPA negotiation status related to the pCODR recommendations were also recorded. So we will now go through and review much of the findings that you sort of see captured here on this slide, and we'll break it down. I've already mentioned what the overall result was, but here's a bit more detail. So 31 final recommendations were issued by pCODR in 2019. 31, that's the total number. And 21 of those, 71% were positive, and 9 or 29% were negative. That's the first pie chart that you see at the top there. So 71 positive, 9 negative. Of the 17 recommendations issued prior to July 1st, 15 or 88%, I just mentioned a moment ago, were positive, and 2 or 12% were negative. That's the graph on the left, and then the graph on the right, as I told you a moment ago, was 50-50. So there were 14 recommendations issued in the last half of 2019, 7 were positive, and 7 were negative. Turning now to the time for review, because how quickly these drugs get reviewed and then ultimately how quickly these drugs get to patients is always a critical concern to everybody. So against that backdrop, and remembering that each passing day is a day that a patient who could potentially be benefiting from an oncology treatment is not getting access to that therapy. So against that very realistic backdrop, For the 22 positive recommendations that were issued in total, the median review time was 218 days, as you see there, with a range from 97 to just over a year. For the negative recommendations, of which, as I said, there were 9, the median review time was 220 days, with a range of 192 to 281. So one way to think about it, or certainly one thing to consider, is it takes basically the same amount of time as a patient who's being told they likely won't get access to public funding of a drug as it does to tell them they may get access to a therapy through public funding. So same amount of time to be told you probably won't get access to this as it is to say you probably will get access to this. But in either case, you're looking at a median time of over 7 months, and in some cases up to a full year. And remember, this is just 2019. We haven't gone back and done a further analysis. But just in 2019, you're still looking at over 7 months for a recommendation, positive or negative, to even be issued so that the process can continue on ultimately to public funding. Now let's start to drill down a little bit. Of the 31 final recommendations, 22 were for solid tumors and 9 were for non-solid tumors. So 22 for the solid tumors, 16 were positive and 6 were negative recommendations for the solid tumor group. And of the 9 recommendations made for non-solid tumors, 6 were positive, 3 were negative. So based on just the single year analysis, again, it's not a comparative, it shows that solid tumors have a slightly higher likelihood of receiving a positive recommendation, a 73%, at 73% versus non-solid tumors at 67%. So there's not a huge difference, but there is a slight difference between which gets a positive and which gets a negative, at least in 2019. Next, of the 31 final recommendations issued in 2019, 15 were for advanced or metastatic cancers. I'm reading the bar graph from left to right, so just so you can follow along. 10 were positive, 5 were negative. 4 were for relapsed or refractory cancers, 3 positive, 1 negative. 2 were for adjuvant therapy, 2 positive, both were positive. 10 were for use in combination therapy. This is an important point. 9 of the 10 were positive, only 1 was negative. And 14 were for use after prior therapy or surgery. 10 were positive and 4 were negative. And just a note here from the asterisk, drugs may be used in more than one category. That's why the numbers don't add up to 31. They exceed the total amount that were reviewed in 2019. So what we're seeing here is a fairly consistent ratio of positive versus negative recommendations by cancer type, if you will. We're calling it cancer type, with the exception of combination therapy. Combination therapy jumps out at us as having a very, very much better ratio, I should say, in terms of positive versus negative. You assume a positive recommendation is better than a negative recommendation. Combination therapy is better than these other ones that you're seeing here on a percentage basis or on a comparative basis. Now let's turn to trial phase. Of the 31 recommendations, 23 were submitted with phase 3 trial evidence. 20 were positive and 3 were negative. 6 were submitted with only phase 1 and or phase 2 trials. 2 of them were positive and 4 of them were negative. 1 was submitted with a phase 4 trial. It was actually negative. And 1 was submitted with pooled analysis or undefined trials. it couldn't be determined where the trial phases were on this one. And again, it was negative. This information is important to note because while Health Canada is approving more and more drugs, particularly in oncology or specifically in oncology, with only phase 2 clinical evidence, what this tells us is that the vast majority of positive recommendations, 91%, at pCODR have at least phase 3 outcomes or have phase 3 outcomes. And so that says to me there's somewhat of a what I'll call disconnect between these two processes. So in other words, Health Canada is saying, yeah, we'll approve a bunch of these medications with only phase 2 clinical data. But when it gets to pCODR, they're saying we really want phase 3. And 91% of the drugs we give a yes to are going to have phase 3 data. For phase 2 trials, the majority are going to be negative. You're not going to get through the pCODR process with only phase 1 or phase 2, as you can see here. One of the most important pieces of information to understand is the rationale behind each of the recommendations. In the case of positive recommendations, it's understanding any conditions that may be attached to a particular recommendation. And as we can see from Table 2, which is taken right out of the report, over 90% of the time, the recommendation called for essentially a lowering of the price or the cost of the drug in 2019. That's not surprising. In the case of a negative recommendation, it's the reasoning behind the recommendation that's important to know. And as we can see from Table 3, not surprisingly, 100% of the time, there were issues around the clinical benefit of the therapies, again, last year that were analyzed. And these rationales have been very consistent for about the last 5 years or so at this stage of the process. And I expect they'll remain this way for the foreseeable future. So this slide really reaffirms what we all know around the pCODR review process in terms of what you get with a positive and what you get with a negative, the conditions in the case of a positive and the reasons for a negative recommendation. Very, very consistent. Now let's make the connection between the 31 pCODR recommendations and what happened to them at pCPA. So, and this is, by the way, as of April 30th. Of the 22 positive recommendations that were issued in 2019 by pCODR, 15 completed negotiations or have completed negotiations with a letter of intent. Again, remember, this is as of April the 20th. 6 are in active negotiations, and 1 has completed negotiations with no letter of intent. Of the 9 negative recommendations, 1 has completed negotiations with a letter of intent. 7 negotiations were not pursued. They simply said, we're not going to, we don't even want to talk to the manufacturer about listing these drugs because of the negative recommendation. And 1 is unknown. We're not sure what's actually happened to that drug. It doesn't seem to have been pulled through the pCPA process. So again, none of what we see here is surprising. When a drug gets a positive recommendation, it typically results in a letter of intent. But with a negative recommendation, those medications almost never get invited into negotiations, and therefore, with very few exceptions over the past 10 years, will never be publicly funded in Canada. We know this from the work that we do every day. If you get a no, there is a huge probability that you are not going to, that drug will never, and I mean never, be publicly funded in this country. What is interesting, as you may note here, is that there was one drug, even from 2019, and even early on in the process, as of April 20th, that got a negative recommendation, but also got a letter of intent. And so that is, that's an exception to what you typically see in this case. And finally, let's take the research findings to the last phase of public reimbursement in Canada, public funding at the provincial level. Again, just a reminder, Quebec was not included, nor were the territories or any of the 6 federally funded drug plans at this stage of the process, was not included in the analysis, sort of thing. So none of the 22 drugs that received a positive recommendation have been funded in every province to date. This is as of the end of March 31st, or as of March 31st, the end of the first quarter. Only one of the 9 recommendations that received a negative, of the drugs that received a negative recommendation have been funded in, has been funded in one province. So one drug that got a negative recommendation, one of the 9 drugs got a negative recommendation, and only one has been funded in only one province. It's a drug for non-Hodgkin's lymphoma, and it's in British Columbia. Of the positive drugs, so these are the ones that got positive recommendations, Saskatchewan has funded the most as of the end of first quarter of this year. They've funded 8, followed by BC 7, Manitoba 4, Ontario 3. 3 provinces have funded only one of those positive drugs, and 2 provinces have funded none of them, absolutely none of them. And one drug has been funded in the most provinces. A drug for non-small cell lung cancer has been funded in the most provinces, of which there were five provinces in total, kind of thing. Now, it should be noted that this work, as I said, only covers the end of the first quarter of 2020 for products coming out of pCODR in 2019. And it can easily take a year for a manufacturer to conclude product listing agreements across the country. So these numbers will improve. I fully acknowledge that these numbers are artificial in the sense that it's a snapshot of a group of medications from the previous year only up until the end of the first quarter. So these numbers will get better, as in more of these drugs will be listed by more of these provinces. But it just gives you a sense, given where we're at in the year, as to how quickly these are coming on board. So just a few slides to sort of draw us to the conclusion of the work that's been done here. What does the research tell us? Well, in a broad sense, well, there's a good probability that a medication that receives a yes from pCODR will ultimately be issued a letter of intent, 68% of the time, based on the analysis from last year. It shows that the percentage of positive recommendations dropped significantly in the latter half of the year. We don't know if that's a trend or not, but it did drop. When a medication receives a no from pCODR, there will be issues regarding the product's clinical benefit, 100% of the time based on the analysis. No question about it. Again, not surprising. It's also it's also highly unlikely that such a drug that receives a negative recommendations will be invited into pCPA, let alone issued a letter of intent. So you're probably not even going to be invited to the table to negotiate, let alone successfully negotiate a letter of intent, although we did see one exception. And even if the product does receive a letter of intent, there is even less likelihood that any province will ever fund it, at least to date. So it was an analysis of nine drugs received a negative recommendation, and there are 9 provinces. So 81 chances for one of those drugs to be publicly funded. Only one province, you saw this on one of the previous slides, only one province has funded one of those drugs. So 1 out of 81 have been funded to date. But there are avenues that can be pursued, and that's what we want to turn our attention to now. So what can you do when pCODR says no? Well, the first bullet is really not what you can do when they say no. It's more of a preparation for no. So instead of reacting to a no recommendation, you're preparing for a no recommendation. And that is simply the premise, or it's based on the simple premise of starting early. As a patient organization, for example, build relationships and deliver messaging to other stakeholders, national review bodies, and provincial officials beginning early on, even before the drug is submitted to Health Canada, to set the tone for what we call sustained advocacy effort. You need to build and start to implement your advocacy effort early on, so that if you do get a no, you've already got all of this foundational content built and you can just continue to go. Second bullet, encourage the manufacturer to wait to submit with phase 3 trials. We saw that there's a higher probability if you have phase 3 trials of getting a yes recommendation than if you only have, for example, phase 2 trial evidence. Now, sometimes phase 3 trials can be difficult to do for several reasons, and this is an issue particularly with the tumor agnostic treatments, where phase 3 trials are difficult to do, again, for several reasons. You should also know that CCSN has been working for a couple of years to encourage pCODR and other agencies to accept less evidence in exchange for enhanced post-marketing surveillance. So it may not always be possible for a manufacturer to do phase 3 trials. We know that, we understand that. You may not, that encouragement may not be applicable. However, again, CCSN is certainly fully engaged around this issue. One could also encourage the manufacturer to resubmit to pCODR if additional data may be forthcoming. That's very common in this process. Patient groups can also engage pCPA directly to request that the medication not be unilaterally put on the negotiations that were not pursued list, to tell them to consider at least entering into negotiations, and even when it's a no recommendation, don't just rush to not give the proper consideration or a full consideration as to whether or not the drug should be considered. Leave that window open for some time. And if negotiations with pCPA do commence despite the negative recommendation, engage both the manufacturer and pCPA directly to encourage them to actively seek a path towards a letter of intent. We work with many patient groups who play that role, even with a negative recommendation. So in addition, there are other pieces that should be considered in the context of when pCODR says no. And a lot of these are pieces that certainly we utilize in the work that we do with patient groups across the country. If you're going to mount a campaign, and in fact, back to that previous bullet on the first bullet on the previous slide, if you're going to plan ahead of time and almost plan for the risk of a no recommendation coming out of pCODR, here are some of the things that you really need to do to get ready in the context of that planning. Gather patient and caregiver stories. Host advocacy training sessions with supporters to make sure that they're ready to engage when the time comes. Establish an e-advocacy hub to facilitate grassroots engagement at the provincial level, even early on in the process. Hold a virtual advocacy day or week in key provinces, including meeting with decision makers. Engage in sustained traditional and or social media campaign. It should be both, of course, but with an emphasis on social media to amplify your e-advocacy efforts, and also consider employing some of the more what we'll call traditional advocacy tools, petitions, postcards, and pledges at any stage during this process. Even with a negative recommendation, all of these tools can be brought to bear to turn the tide of that negative recommendation. Even when there's a yes, though, in the current world of COVID-19, there may be some delay in the issuance of their of the work being done, for example, at the pCPA level. So this directive or this announcement was put out on March the 23rd, in which they told the manufacturers and others, look, there may be some delay in the process at pCPA. So as these recommendations, even positive recommendations, are coming out of pCODR and being considered or sent into the pCPA process, there may be some delay. And of course, any delay in any step along the way of the process here means a delay ultimately in access to medications for patients, which should be a concern for everybody. Now, we are starting to see some activity at pCPA, some more movement at pCPA, so hopefully things are moving in the right direction. But I would suggest to you that the impact of COVID-19, and again, this is on yes recommendations, not even on no recommendations, will be felt for some time, which again will surely mean delays for patients who need publicly funded access to oncology treatments. And finally, this is the last slide. While the pandemic is still with us, and certainly for the rest of 2020, engaging decision makers and others to ensure that even yes recommendations from pCODR progress through the remainder of the reimbursement processes in a timely manner will be critical. Because you remember that analysis of 2019 was pre-COVID-19, so it was when things were moving along quite seamlessly. But based on that text you just saw on the previous slide, that's not the way things are going right now at the pCPA stage. And so here are some ideas to do exactly that, to kind of continue to prompt the process through even when it's a yes. Continue to build relationships and deliver messaging that we talked about before. You'll notice there's an overlap between some of the stuff here and some of the stuff that we talked about in the case of a no recommendation. Still want patient and caregiver stories, still want to train advocates how to do this kind of work. And you still want to engage in a sustained social media campaign. You'll notice we left out traditional media there because traditional media right now is pretty much consumed by COVID-19. So really, I think you want to focus on not traditional media but social media, and consider framing your need within the context of the COVID-19 crisis. I think is another consideration. Consider launching a sustained e-advocacy campaign targeting pCPA in the provinces. And then, and this is going to become very important now, consider planning a virtual advocacy day targeting one or more of the provinces. When I was asked to do this presentation, there was no COVID-19. So we have had to adapt not just to when pCODR says no, but even when pCODR says yes in the context of COVID-19. And I think for the remainder of the year, there are going to be challenges both with no and with yes recommendations. And that's why we wanted to give you some ideas and insights in the case of both circumstances. And that's it. Andrea?
Hey, wonderful. That was great. So informative. And we do have a couple questions that have already come in. And as Ryan will answer those, feel free to type in any questions anyone may have now, and I will tell them to him, and he can have the opportunity to answer. So we have one here. It says, does the pCPA send letters of acknowledgement for all drugs post HTA, or only those that receive a positive recommendation or for which there is a potential desire for negotiation?
So according to the new website, I can't tell you I can't answer that question definitively, but according to the website and the process, excuse me, that they have laid out, they say that at the conclusion of the consideration of all medications coming out of pCODR, they will either issue an engagement letter. It's called an engagement letter. They will place the drug on hold, or they will close the file and not negotiate. My understanding is that in all three cases, yes, the manufacturer will be informed. A communication will be issued to the manufacturer saying you fall, well, we know that obviously the engagement letter, that's easy, but that if you fall on one of those two other lists, or your fate is in one of those two other ones, yes, the manufacturer will be advised in writing. That's my understanding.
Okay, another question we got, it came in while you were speaking about the recommendations, positive versus negative, and the statistics that were there. And we have an attendee that was wondering if there was, or what was the significant event that occurred July 1st of 2019. So I guess there was a bit of a shift.
It was simply, Yeah, it was simply it was simply a way to differentiate between the first half of the year and the second half of the year. So there was no sort of magic to that. We just because the analysis wasn't a multi-year analysis, and so we couldn't say, oh, let's compare 19 to 18 to 17, all the way back kind of thing. We decided to somewhat artificially just divide 2019 into the first half of the year and the second half of the year. Was there going to be consistency in the first half and the second half of the year or not? We found there wasn't, but I can't tell you whether that's a trend or not. It's what we found in 2019. So for the first quarter of 2020 or for the last quarter of 2018, what were the numbers? We don't know. We haven't done the analysis, but it was simply a way to be able to compare something within the context of a single calendar year.
Okay. Next question. Is there a reason why some provinces are more active in making recommendations than others?
In making recommendations or in funding certain drugs? Because provinces don't make recommendations, right? It's the national bodies that make the recommendations.
Yeah, so regarding the public funding.
Sure, yeah. So in terms of when they get there, it not really. We can see, for example, that from this analysis, that the pickup from 2019, at least to date, or at least as of March 31st, and again, it's only one quarter, so I mean, it's hardly representative of the entire year, but we can see that the pickup has been relatively slow, and you can also see, for example, which kind of surprised me a little bit, the province that led the way with having made listings or having listed drugs coming out of 2019, I believe, if I'm not mistaken, I'm just looking back here, was Saskatchewan, and so that is not typical. I would say Ontario tends to list quickest, not in all cases. I will tell you, just based on where things are currently at, and this isn't just in oncology, this is across both oncology and non-oncology drugs, Ontario tends to come on quickly. Alberta seems to be really not funding much of anything at the moment, and I would suggest to you, given what's happened over the past couple of months with the collapse of oil prices and COVID-19, that may become even worse, although if you're not listing anything, I don't know how it becomes worse, but that trend, I suppose, or that reality may continue. Prince Edward Island lists few drugs, period, ever, so that again is relatively consistent. And it's British Columbia that's really kind of the wild card here in oncology. As many of you may know, they used to lead the pack in terms of quickly funding many oncology drugs years ago. That has changed significantly over the past 5 years plus now, where BC is listing fewer drugs, and they're taking a longer time to list those medications. But I was surprised to see that Saskatchewan sort of led the way, at least in this limited analysis that we've done, as well as Manitoba. I was not surprised to see that New Brunswick, Nova Scotia, and Newfoundland had only listed one of all of the drugs that received a recommendation coming out of 2019. So it's pretty consistent.
Yeah. Okay, another one here. Has there ever been cases of a final recommendation being negative, which was later turned into a positive recommendation without a manufacturer resubmission? And they went on to say, i.e., could advocacy alone overturn a negative recommendation?
Coming out of pCODR, if a final recommendation is negative, then there is no mechanism to change that final recommendation other than a resubmission. So in other words, think of it this way. When a final recommendation is issued by pCODR, their job's done. It's over. There's nothing else to re-engage around because the file is closed. It's done. It's over. They've issued a final recommendation. And as the question points out, the only way to change that would be for the manufacturer to resubmit. So there's no mechanism, formal or otherwise, that would allow a patient group to engage pCODR as a body to change their final recommendation. That's not possible. However, moving forward through the process, which is why we talk about then it goes to pCPA, then it goes to the provinces, it's only on a go-forward basis that advocacy can have an impact to say, hey, even though it got a negative recommendation, we still think that you should enter into negotiations with the manufacturer. And quite frankly, even if it doesn't go to pCPA, or it goes on the what used to be called the no negotiation list, there are ways to get it off of the no negotiation list. There are ways to get drugs off the closed negotiation list where they had been negotiating, but then the negotiations closed unsuccessfully, and to be able to get a drug off of that list. We've done that through advocacy on both lists, both the no negotiation list and the closed negotiation list. And then finally, despite the fact that a drug received a negative recommendation, and even if it was not invited into pCPA, you can always use advocacy at the provincial level to bring pressure to bear on an individual province to list a medication. That's very challenging. That's extremely challenging to do, but it is possible to engage in that kind of an effort, but certainly not preferable at that stage, for sure.
Okay, and then there's a question kind of piggybacking off that one, where someone was wondering if you know of an example where advocacy was effective in are the suggestions meant for the advocacy, if it's meant for after a negative recommendation, and if so, do you have an example of an effective way where this has kind of turned it around?
Where you've had a negative recommendation. So we've had cases where a negative recommendation, the drug was sent to the no negotiation list, and in that particular case, it was a drug for idiopathic pulmonary fibrosis. A number of years ago, it was sent to the no negotiation list, and eventually got off the no negotiation list and successfully was concluded through pCPA. None of this, of course, is done in isolation. Advocacy wasn't the only component to all of this, but that's an example. And right now, there's a drug that is in the pCPA process it's a drug for pulmonary arterial hypertension, PAH, and it's in the process right now of being negotiated with pCPA. It had been in negotiations, and it got sent to the closed negotiation list. So they were discussing it, and it got closed down. And that drug came back in large part, significantly as a result of a very, very engaged patient advocacy community to get that drug off the closed negotiation list, and is now in active negotiations, and we assume will receive a letter of intent. But that's an ongoing one. So there are some examples. There are also some creative examples of where there was another case where a drug got sent to the no negotiation list, and we were able to convince through advocacy to get a province to fund the drug on an interim basis or on a temporary basis. The province was Ontario, on a temporary or interim basis, while further clinical evidence was coming forward that would get the drug off of the no negotiation list and ultimately back before pCPA. That's what happened. The drug ultimately went through pCPA, got a letter of intent, and ended up being funded in I don't know if it's every province, but certainly the major provinces in Canada.
Okay. We have another question. In the last 2 years, has CAPCA's PFAC member involvement improved pCPA's negotiation process with regard to patient accountability and meeting the 90-day timeline?
Sorry, what was the first acronym? Has who?
It says
I didn't get that answer, sorry.
CAPCA.
Or pCPA maybe? So
yeah, I think so.
pCPA. Okay, so sorry, read the question again. pCPA, yeah.
So in the last 2 years, has member involvement improved pCPA's negotiation process with regard to patient accountability and meeting in the 90-day timeline?
So the 90-day timeline is pCODR. That's pCODR's timeline, not pCPA's timeline. And so I'm not exactly sure. I think the timelines for the target 90-day timeline for pCODR or for pCPA, excuse me. Yeah, I think that some of the pressure that has been brought to bear by patient organizations engaging with pCPA, and as you all know, there is no formal process for patients to engage in pCPA. There is at pCODR, but not at pCPA. But nevertheless, the fact that a number of patient groups have taken it upon themselves to insert themselves to a greater or lesser extent in the pCPA process, I think has brought to bear, to some extent, at least this target of 90 days within the pCPA process over the past couple of years. I don't have the evidence to suggest whether or not that time is improving. I think it is, just anecdotally based on the files that we work on, but I can't tell you definitively that it has. I will tell you though, I'm working on a lot of drugs that are still way past 90 business days in pCPA, like way past, like twice as long, 3 times as long, that are still sitting in pCPA in negotiations. So I know it said that they didn't have that many active negotiations, but that number I think has probably been reduced relatively recently, because up until relatively recently, well, still one today in particular, but up until relatively recently, we had a number of them that had been in for well over 6 months, easily over 6 months in pCPA.
Okay, we have we'll try to get through just a couple more.
Sure.
They just keep coming in, which is amazing. It's a great conversation. So is there any data on the rationale provinces relied upon when failing to accept pCODR positive recommendations?
No, not that I have. The data may exist. I haven't seen it, and we haven't engaged around it. I will say though that certainly you could take a look at what's come out of pCODR and extrapolate or draw the link between, of those drugs, what has ultimately been publicly funded. And in all fairness, you'd probably have to do this over about at least a 1 year, 18 months, maybe even 2 year lag. So if a recommendation is issued on, December 31st, 2018, you'd probably want to give your analysis a full 2 years to find out, hey, did that drug get publicly funded ultimately, and on how many of the provincial formularies? But I would suggest to you that exercise in some ways, while, it might be interesting, is really missing that piece in between, which is the role of pCPA. And remember, the provinces, pCPA is the provinces. That's who it is. So when pCPA issues, or when a letter of intent is concluded by pCPA, you sign as a province. And then the manufacturer brings that agreement that you, Alberta, signed to you, Alberta, and says, can you, Alberta, turn this letter of intent that you signed into a product listing agreement? So if you're Alberta, you're looking at your own signature. You're looking at your own signature that said, I agreed to negotiate to enter into a contract. You might change your mind, but it is the provinces who are in this process. So my point is that a proper analysis would look at what we did here, although again, just a small snapshot in time. It would look at the recommendations coming out of pCODR, what happened to them at pCPA, and then ultimately what happened at the provincial level in terms of product listing agreements or funding decisions. You have to look at all three components to ultimately, I think, develop some kind of an understanding of trends or expectations. But even with this limited analysis, we know that some of what we're seeing here is very consistent with what typically happens, for sure, as I highlighted in some of those slides.
Mm-hmm. Another interesting question here is, what can cancer patients do if the drugs were rejected? Can the pCODR-based drugs still be used? And what do patients do then?
Can the what drug? I'm sorry, Andrea.
Says,
what drug?
I guess the one, like the drug that was up for recommendation, the drug that they were doing the trials on. That drug, can that one still be used? Or is, like, when it's closed, it's no longer available?
Again, if I'm understanding the question, so I'll back up for a second. So all of you know that this whole process that I've been walking through with you pertains only to publicly funded access to medications, not to drugs that are paid for through private insurance, and not drugs for which you can pay cash. You may know, because now the vast majority or the majority of drugs, even in oncology, are delivered or can be delivered on an outpatient basis. You're free to buy them if you've got the money. Most Canadians don't, of course, but if you've got the money, you can simply buy the medication. So all of this pCODR review and recommendation, pCPA negotiation, letters of intent, and then ultimately public funding pertains only to those medications that are delivered through public funding. Now, in oncology, that includes all the medications delivered in a hospital. That includes many of the medications, potentially some of the drugs delivered outside of a hospital, depending on which public formulary you're talking about. So, if you have private drug coverage, or if you are one of the very, very few Canadians who could actually pay for these drugs out of pocket, none of this matters. None of this matters. You're free to go out and access those medications. But if you rely on public funding, then it's incumbent upon anybody who wants publicly funded access to those particular drugs to potentially engage in these processes, to potentially make your voice heard, again, even long before the drug even gets to pCODR. But certainly as it goes through the pCODR process, through a formal mechanism that they have that I talked about, even at the pCPA level, where there's no formal process, but where patient groups and others do engage, and certainly at the provincial level, by pressing and engaging provincial decision makers who ultimately make the final decision. They're the ones that make the final decision. pCODR is just a recommendation. It's significant, but it's just a recommendation. pCPA is just a letter of intent. It's significant, but it's only an intention to enter into a contract. It's at the provincial level where advocacy is critically important, because then you are looking at a decision maker, the person who can and will make the final decision, in the eye, to let them know what it is that you need on behalf of the patients, for example, that you represent. So engagement is important all along the way, but certainly at the very last stage, it's critical.
Okay, and we'll do this last question here. We have somebody wants to know if you have any suggestions of actions for drugs that have a letter of intent that was not approved for reimbursement in any given province.
So letter of intent, but then it never ultimately received, it was never listed in any of the provinces. Yeah. I think that's the question. Yeah. Okay. So in that particular case, I think that that's where, and it kind of is akin to what I just mentioned a moment ago, that's where you really, as a patient advocacy group, need to, through some of the suggestions that I had on the kind of what you can do slides there, that you really need to engage provincial decision makers at the grassroots level, so MPPs, MLAs, MNAs, MHAs, depending on what province you live in. So provincial decision makers, elected officials, drug plan managers, ministers of health, bureaucrats, ministers' offices, all of that kind of stuff, to say, you signed this letter of intent. You signed it. You said you intended to pay for this drug, or you intended to enter into a negotiation. It's now been 3 months, 4 months, 5 months, 10 months, 1 year, 2 years, and you've done nothing. And there are patients in this province who need access. Why have you done nothing? What's going on here? And I would advise that you press them and that you mount, if possible, a sustained advocacy campaign in that particular case. Because if none of the provinces, let's take this scenario, if none of the provinces who signed a letter of intent ever end up funding the drug, then what value is pCPA, period? Why does it even exist if nothing is going to happen as a result of the issuance and the signing of these letters of intent? They're completely worthless. So I would really press a particular province or number of provinces, depending on what kind of work you're doing, to say, you signed, but nothing's happened. What, why? And start to put some pressure in that particular case.
Okay, well, that's amazing. We'll stop it there. So I'd like to thank everyone for attending the webinar, and CCSN would love to thank our incredible presenter today, Ryan Clarke. The video and slides will be available later today on our YouTube channel and on SlideShare. Feel free to check out our previous webinars, and you can find the links to them on our website. This is just one of many webinars we have scheduled for 2020. The next 2 webinars will be on COVID-19 related topics, with the next one Thursday, May 14th. So next week, it will be hosted by registered dietitian Linda Soberens, discussing healthy eating at home while in quarantine. And then the second one will take place the following week, Thursday, May 21st. And that will be with Rachel Mark of Inspire Health, presenting on home exercise and lifestyle while in isolation, when you can't visit your physiotherapists and all of those other healthcare providers. So you will receive an email with more information once the registration is available. And again, thank you, Ryan. This has been a wonderful session with you. And I hope everyone enjoyed their time.
Great. Thanks, everybody.
Take care.